Hello, everyone. We are in this session of MENASO Education Academy Cerebrovascular Grand Round. Thanks for organizing committee. Thanks, Sepi John, for inviting us. I'll be moderating this session with Professor Wanzan. We have two speakers, like young stars. Fatma Gerakarsu from Turkey and Razvan Radu from Romania, Bucharest. So the first topic will be refractory LVO and strategies to increase recanalization. Fatma Akarsu has been trained in Eskişehir Osman Gazi University as a resident, then followed by critical care and neurointerventional training in my center, Eskişehir. Then she has finished her fellowship in St. Mike's Hospital, University of Toronto, under the mentorship of Gustavo Sapoznik and other esteemed colleagues. She'll be presenting refractory LVO and strategies to increase recanalization. So thank you, Fatma.
Hi, everyone. Thank you, Dr. Özdemir, for this great presentation for me. And thank you for organizing committee to bringing us together. My topic is refractory LV1 strategies to increase recanalization. All we know is in early stunt retrieval trials around 2010 to 2015, unsuccessful reperfusion rates after mechanical thrombectomy occurred in roughly 30 to 40% of patients. But with increasing operator experience, workflow optimization, and newer devices, recent RCTs show that these percentages drop down 10 to 20%. And because we become so accustomed to the high success rates of mechanical thrombectomy, experiencing a thrombectomy failure can feel particularly frustrating for us. This review is a good review for access issues about arch anatomy and supraartic arch anatomy, and nearly 1 in 23 thrombectomy procedures fail due to access issues, while these failures are more commonly linked to carotid tortuosity rather than arch anatomy. Data also show that up to 47% of patients have challenging arch features. So this chart also really useful for understanding the resistant thrombectomy failure. So one is 32% of failures occur because we couldn't reach the target occlusion, and 57% of failures occur even we reach the clot, we couldn't just suck it out or retrieve it out. So the first part, why we couldn't reach the clot, is because the arch anatomy and maybe wrong device decision, maybe just related to arch. And this cohort study just showed that 20% of stroke patients undergoing thrombectomy were shown to have type 3 aortic arch, and nearly half of the patients presented with supraortic arterial tortuosity, most commonly elongation. So these anatomical challenges are more pronounced in elderly patients and female patients. So our patients are generally elderly, so we commonly see these arch anatomies. So ICA tortuosity was independently associated with lower rates of first pass recanalization and frequency of post-mechanical thrombectomy, ICH. We all know that. So when to come to overcome all these obstacles, when the anatomy pushes back all your system, the balloon anchoring technique can really be a game changer. By inflating the balloon proximally, we gain the extra support, the aspiration catheter, then is withdrawn slightly and pushed gently to the distal lesion. There is lots of techniques like this. The neighbor one slingshot technique. This is also for distal cavernous segment side tortuosities. You inflate the balloon more distally. So another anchoring technique is stent anchoring technique. All our purpose is just bringing our catheters close to clots. So here's an example from this study. There's an empty occlusion. The distal access catheter just couldn't pass through the ophthalmic artery orifice. We generally face this issue. And we put a stent retriever just through the M1 site, not reaching the clot. With anchoring this stent retriever, we could able to reach the clot, touch the clot, and then put the stent retriever again at the clot position and doing our whatever we want technique. So this is anchoring technique with distal stent retriever catheters. BGT, I've never used this one before, to be honest. But writers recommend this one, and adding there is no technical issues about this technique. They just push the inflated balloon directly. So this is one of our case. We just did this patient's thrombectomy 2 days ago. So there's one just after the arch. So the second one on the cervical carotid artery. So third one, fourth one, fifth one, loss of tortuosity, anti-occlusion. What I did for these patients, I generally do combined techniques rather than isolated aspiration. But it was like 2 or 3 times with different multiple techniques. I couldn't retrieve the clot. So I get a shot when the stent retriever opened there. It seems like just clot. There's no ICAT, there's no other issues. So I decided to do this with stent anchoring technique, then isolated aspiration. It worked, and we could able to open the ACA. Then I go for another run, and we open the vessel. So for the arch problems, beside of that, the main problem, one of the main problem is tandem occlusions for us for resistant thrombectomy, because like passing the atherosclerotic lesion, stump lesion is sometimes being a nightmare for us. So in this article, we also use this technique. We just use a micro guide wire, pass through the ICA stump, then angioplasty with a low profile balloon, undersized, then half deflated balloon over the plug into the occluded lumen of the ICA. We use guide wire pushing through the atherosclerotic plaque with half deflated balloon. It prevents the razor effect, which is what is the razor effect? Razor effect is if you push through the guide catheter through this atherosclerotic plaque, it can damage the plaque, embolus, and other stuff. But if you use a half deflated balloon, it prevents the anatomy. So T-tap technique for tandem lesions. It's we just put a stent retriever here on the occlusion site. We don't know where's the occlusion, but we generally choose the M12 ICA long stent retrievers. Then inflate the balloon here on the lesion. After inflation, just go through the intracranial segment and do whatever we want. Recanalize the vessel, and if the plaque looks ugly and other multiple issues, you can put a stent on the cervical ICA. This is also one of our tandem case with 78 years old male, 4R from symptom onset, NHSS 22. But we were lucky. We could able to push our all catheters through the intracranial segment. So we did a combined technique and recanalized the vessel. Here is our long sheet. We don't know what's going on the cervical ICA bulbous side. So we pushed back the long sheet with manual aspiration, but boom, another MCA occlusion after this maneuver. So we did another thrombectomy, recanalized the vessel, and decided to put a stent for this ugly lesion with a distal protection with filter. So end of the story. Recanalized intracranially, extracranially, and patient did really well. It was old strokes. And the other option for passing the obstacles for arch anatomy, ICA tortuosity is just changing your direction. So direct carotid puncture is one of options. We sometimes use this technique also. This is 81 years old male, 2 R's from symptom onset, NHSS score is 20, and look at this arch. It's bovine, type 3. I don't know where the left ICA is going and coming through. So for this patient, actually, personally, I didn't want to lose time with these access issues. So I directly did a carotid puncture. In our center, we use a short sheet. We moved the short sheet directly to ICA segment. So no other long sheets, no exchange maneuvers for carotid lesions, carotid puncture. We generally go with the distal access catheter, and I personally use combined technique for these patients, and it worked. But there's some hazy image on the superior division, so we decided to go for that one also. But the angle is 90 degrees, so I couldn't move my distal access catheter. It's 5 French through the superior division. So I again did the combined technique, and it worked. We have been following this patient without any deficits, MRS score 0. All these are for we couldn't get the clutch, target reason couldn't reach scenarios. So the second part and the most common part is it happens when we reach the target occlusion and couldn't suck the clot, couldn't retrieve the clot. And common causes for this is underlying atherosclerotic disease, arterial dissections, partially occlusive thrombi or different thrombi origins. So occlusions with long clot burden or fibrin-rich heart clots are more likely to resist retrieval. Organized firm clots engage poorly with stent retrievers, often requiring multiple passes each pass may only fragment the thrombus, and such clots can also induce arterial spasm during retrieval attempts. So also it's hard to see on CT fibrin-rich thrombi, so RBC clots more commonly see on CT as hyperdense artery sign. These are clots from our center. This patient has mechanical heart valve, aortic mechanical heart valve, and after thrombectomy, we retrieved this one. So patient had a TEE, transesophageal echocardiography, and that one showed a huge pannus over the valve, which we cannot resolve this material with warfarin. Unfortunately, patient underwent surgery. And the second one, this one is a infective endocarditis clot. So this patient has a end-stage GI malignancy, and his clot looks like this sticky, long RBC clot. And this is a coronary stent, which proposed to put in a V1 origin stenosis, but during the procedure, stent just moved through the left ICA, like dancing there in front of our eyes. So we retrieve it with another stent retriever. Thankfully, patient is now without any deficits. So when we look at the histopathological composition of thrombi, it's very common these days, this type of studies. Today, we generally focus on atypical clot composition rather than just fibrins. So these ones are septic emboli, atoroemboli, calcified emboli, and fat emboli. These are tend to be more resistant to first pass effect. So we should keep in mind all these clot types. The other issue with the resistant thrombectomy, it could be an intracranial atherosclerotic disease. There is signs on CTA and CT. Tapered vessel sign is a sign for intracranial atherosclerotic disease. When you see a distal abrupt cutoff, it's cutoff sign. It generally not the ICAT. It can be a emboli source. And also there's another two type of definition. One is branch type occlusion, which generally refers to embolic origin. And the other type is truncal type occlusion, like B. It generally refers to intracranial atherosclerotic disease. So there's no standardized treatment for underlying ICAT or other etiologies following failed MT. But rescue therapies becomes more accepted in the endovascular community. But several questions arise. When to start intravenous antiaggregant therapy? Should we use just balloons, or should we use both balloons or stents for these patients? This study includes more than 7,000 patients and close to 1,000 failed mechanical thrombectomy, just divided into two groups, rescue therapy and medical management group. And rescue standing is associated with better 90 days outcomes and mortality. And these patients, interestingly, symptomatic ICH is significantly lower in rescue standing group. So this is again from our center. It's a tapered sign. When you look at the early phase CTA, there's a slow flow here, and late phase, there's also flow here. So if we have a suspicion on ICAT, we generally start in, again, combined technique. So we did it and recanalized the vessel, but there is intracranial atherosclerotic disease here. So we wait 10 minutes to see that the vessel is closing again. And I decided to do a balloon angioplasty because patient's aspect was pretty low initially, and he wasn't on any antiaggregants. So I tried my chance with balloon first. And again, not a bad recognition. But after, again, 10 minutes, vessel closed. So I decided to go for intracranial stenting. And 10 minutes after stenting, we could able to get this recognition, this flow. But unfortunately, this patient didn't get very well, had decompressive surgery. But after a year, he could able to walk with assistance now. So this most frequently cited work showing that catheter to vessel ratio is major determinant of primary aspiration success. So also this picture also shows that we can pass all angulations with larger catheters. This is also a famous slide. And when it comes to technique, your clot is just sitting here. If you do your aspiration from here, there's no chance to recanalize this vessel. Arterial collapse is another issue with the resistant thrombectomy. It's all about physics. We should keep in mind. This video is from Dr. Mark Ribot's lab. And if you use a static aspiration to vessel, look at that collapse. But if you use a stent retriever inside of the vessel, there's no collapse like the first one. And when it comes to suction, look at this force. So another rescue technique is Y stent or double stent technique. And there's a 7-to-7 trial is ongoing now just to use this technique as first-line therapy. And it seems it works. You can use stent retrievers of 2 different sizes, and longer the stent retriever is, better the result. So for double stent technique, there's a systematic review and meta-analysis. It showed that dual stent rescue techniques have a safety profile comparable to standard thrombectomy with symptomatic ICH rates around 5 to 6%. So when it comes to rescue strategies, take-home messages, switch device or technique, personally, if I'm really confident about my first technique, I generally not insist on, again, with the same technique. I generally change my technique, change my devices, change my way. And alternative access, we can evaluate the access on CTA, and we can just go with the direct radial puncture, pertussis puncture for these patients, for the tough anatomies. So knowing the ICAT, keeping in mind is crucial, and strive for first pass effect, because more passes we do, more stress we induce the clot, and it's gonna get more sticky, more difficult to retrieve. And surgical embolectomy, I don't have this option in my center, but some centers really do this acute embolectomy procedure. And thanks.
Okay, then we continue with Dr. Razvan Radu. He's a vascular neurologist in Bucharest, Romania. And I first met him in Montpellier, where he did his training for neurointervention, and then went back to Romania, and there he started the network, the stroke network, and I was able to visit him last year, and it's some fantastic work that he did there in several centers, doing a lot of thrombectomies in his own center in Bucharest. And I'm happy to hear what he thinks about large bore catheters, and he will show us some cases. Razvan.
Thank you very much, Wim. I hope everybody hears me fine and you see my slides right now. So yes, I'm running a very busy center in Bucharest. We're right now doing 445th. We have our 445th thrombectomy this year. So we're busy and we are not a lot of people as opposed to a lot of centers. We are 2.5, as we like to say, because the interventional radiologist also helps us out. And this is why we do a lot of procedure, and the time is of essence to us, procedural time. So you will hear a lot of things about procedural time. I have some disclosure, and relevant to this talk is that I will speak a lot about microvention products, and I use Sophia 88 as my go-to large bore catheter, mainly because it was the only one available in my country this year. So first of all, why do I want to use them? These are all results of thrombectomy audited last year. So our first pass effect rate was 44%. We were going 80% with aspiration, usually aspiration first. We do a lot of snaking, and if we cannot snake, we try with a guide wire only a lot of times, and this helps. So out of 50% of the time, we managed to snake our catheters up there. And this technique, we have our around 93% TK2B3 and around 80% TK2C3. And these are all basically our results. But the idea with aspiration, as you all saw, is that it works fine when you can fit to the vessel diameter, and you will have good results while fitting to the vessel diameters. And for us, our go-to catheters for M1 were between 0.70 and 0.72, M2A1, P1 we were choosing, right, Red 62, or even a 0.70 catheter if it was a big M2, 5 French Sophia, 0.55, and we were going for the larger Red 43s, Vecta 46 for the small vessels. Of course, mini stent retriever was our go-to approach for really distal vessels. But for the ICA, we had a big problem. I personally had a big problem with doing aspiration first for the ICA because I had bad results, and because, as you can, the 0.70 catheters were not so useful. Now, if you look in the ICA trial, ASTER trial, we see that combined technique only accounts for 30% of first pass effect in ICA terminus lesions. If you do stent alone, it's much less. Usually, if you do aspiration alone, it's around the 20% of the time. And the TK3 after the first pass for ICA terminus lesion was very rare. Even with combined technique in the ASTER trial was around 13%. So the idea that the stent is really protecting and is really very useful here on randomized data, it's not providing the same results as in M1. And we have around 25, in my center, we have a 25% cases of ICAT. More so, the procedural duration of these techniques is around 47, 48 minutes, and our median procedure time is around the 25, 26 minutes. So this is usually longer in these cases. Now, when we look if you should do aspiration first, you have bad results, right? For ICA terminus, of course, you have better results with combined technique. But what I'm pointing about is embolization to the new territory. Even if you used stent retriever or if you used just aspiration, there was no significant difference between embolization to the new territory, in this article at least. So basically, you still get 20% of emboli while dealing with an ICAT out of their results. So I was looking a little bit at the large bore data, and this is the imperative trial Zoom. We do not have it in Europe, I think, or at least in Romania, it's not available. This is US data, and they had like TK2B in 83%. They had around 35-40% of ICA terminus lesions with a median growing to TK2B puncture time of 90 minutes. So this is very fast and very efficient to use these large bore catheters. And emboli to new territory with these large bore catheters was very, very low in this trial, 0.8%. So I know Wim is a balloon guide user. So the idea is what they managed to achieve probably with this large bore catheter, from my perspective, is flow control. So it's the same results that you can see in this balloon guide study from England, in which they randomized with balloon guide and flow arrest and without balloon guide flow arrest. And this time with a procedural time that is nearly double in the balloon guide group, they managed to have emboli to new territory of 1.5% because you control the flow. And I think large bore catheters help you control the flow. So this is why I started using them, especially for large clots in the ICA terminus lesion, where before my go-to approach was 6 French aspiration, embot trap, or solitary usually, but I still had problems, emboli in the A1, had to do several passes, so I waited for the large bore catheters to come to the market. There is always the option, and we saw from the speaker beforehand, to use the double stent retriever technique. You will gain excellent first pass effects in this situation, around 60% with good results. For me, it's not an option because in order to do a double stent retriever technique, first it's a cost problem, but secondary, I have to prepare 2 microcatheters, 1 aspiration catheter, just the number of drips that I have to prepare, while being 1 scrubbed individual in the angio room and another nurse that's giving me material, and this is my setup in the angio room in Bucharest. It would take a lot of time, and it will enhance the procedural duration just by trying to prepare all the materials to get the stents up there. So I was focusing on large bore. This is the first case from Montpellier, just pointing out what I started doing with the large bore, right? It's a T occlusion that we did at that time, and my mentor there, Gregory Gascu, always advised me when I have a T occlusion, I put a balloon guide in the carotid artery at that time, that I should inflate the balloon guide, and because there is a stagnation and blood is not flowing up, I can try to aspirate on it. And this is an IBC aspiration by balloon guide technique. It's reported to have chances of recanalization around 5% with short procedural times of 14 minutes. These are some case reports that were published at that time, and I was regularly doing this. But the problem, in order for this to succeed, you need to mount your balloon guide up until the petrous segment, because otherwise, even you aspirate from the cervical carotid artery, you can see that you're collapsing always the artery, so it's very difficult for you to bring back the clot from the T region with this remote aspiration. So this was my first 88 catheter, T carotid region. You see a straight anatomy usually. I put in an arrow 8 French, I put in a Sophia 8, tried to snake it up until the cavernous segment, couldn't pass it, connected the 50cc syringe to the Sophia 8 while I was opening my Sophia 6 in order to try to pass the cavernous. And then I saw that I have blood in the syringe and everything, so when I looked there was a thrombus there, so I just did a run and I had the TK3 recanalization by remote aspirating. And it's very curious, is this a pass because we didn't even go intracranially, or it's like, would you count it as a pass? The procedure went fine from the start. So after that I started using this technique. And I will show you a couple of cases and discuss with you how I'm using these catheters for the T occlusion, which is my go-to occlusion for them. So 83 years old, an age of 20. It comes in from different center. I don't have imaging because they are sending just pictures on WhatsApp. This is the initial run. So you can see there is a T occlusion, there is a small progression of the contrast medium inside the carotid. Sophia 80, how I put the Sophia 88 in is that I usually go with a diagnostic catheter and always with a 38 to 160 centimeter guide wire Terumo. If I see that it's a T occlusion because I don't have good imaging from a lot of centers that are sending us our patients. Then I exchange immediately for an arrow 8 French 80 centimeters, and I take a balloon large bore catheter, and you can see here how I catheterize it slowly with the Terumo 38. You can see that the vessel is straightened by the Terumo 38, and the Sofia 88 passes very easily inside of this vessel. At the start, I will just, and it goes up to the cavernous, where I usually start to do a remote aspiration, because I always think that in this carotis there might be some clots, some fragments, and I want to clean it up when I go up from the petrous to cavernous segment. What I want to show you and emphasize, this was my experience also from these cases, and also while I was using RED 78 and Destination 9 as a catheter, Destination 7 as a go-to guide catheter for the RED 78, is that in this anatomy, while you put the guide wire up, you can see that the carotid gets straightened. So I had a tendency to try to push the long sheet up in order to have more support. I'm not doing it anymore because it's not necessary for the large bore, but it always results in severe spasm. And at least with the Destination, I had some dissections. I'd never had dissection with the arrow, which is more supple than the Destination. So right now, I wouldn't advise for people to move the long sheet, the arrow, more than the carotid bulb. There is where I stay, and I always pick the arrow because it's 80 centimeter and gives you more free length to the catheters, the aspiration catheter intracranially, as opposed to if I would have used a Destination, which is 90 centimeters, the shortest version. So I have a problem with length with that, with some catheters. Going on, in this patient, we did aspiration from the cavernous. We got a little bit of improvement, and then we couldn't pass, so we just took a guide wire. This is a Chikai Black probably, and the Sofia 6 catheter, and we passed with the Sofia 6 very easily, the ophthalmics on the guide wire. You can see in this picture, I think it's very important for junior people to understand. The black part of the guide wire, whatever guide wire you have, is very floppy, it's very flimsy, offers no support. If you need support for anything, the support will come on the middle part, the gray part of the guide wire, so you have to push it up. It's very important for large aspiration catheters. You want to track them down, or for coronary stents. And sincerely, I do not see a lot of benefit in using also a small microcatheter with a guide wire sometimes, because I believe the support comes always from the guide catheter. The microcatheter, the Headway 21 or whatever one Phenom, whatever you use, is like a spaghetti. It doesn't offer a lot of support. It can only reduce with slack when it comes to the ophthalmic ledge, but it's usually not big enough. Now, after you aspirate in this kind of situation, when you reach the T, you can see in the second picture, you are blocked here. And then you stay for 20 seconds or something around this. I'm aspirating by syringe, and I just go down around 20 millimeters or something, and then you still get the flow into your Sofia. I'm not pulling it out of the cavernous segment. When I have flow, I stop because it makes it easier to redo a second pass if I need it. So, and usually you just have to come a little bit down in the carotid to move from the T, and you will get your clot in your syringe. And this was the case in this situation, and you see a very good and nice recanalization on this pass. This is a case of my colleague who has done it recently. Patient came in, fellow started the procedure, no imaging was available, so they saw it was also a T occlusion. It was normal setup for my colleague, which is a Neuron Max and a 6 French aspiration catheter. So they took a 6 French Sophia in these cases, and they start to do 4 passes of aspiration without any success. Now, when I'm speaking about 4 passes, do not understand that we were spending a lot of time doing these 4 passes. Anatomy was very good. So my colleague just snaked the catheter to the T, connected the syringe, stayed for 20-15 seconds, brought it back, nothing happened. Did this once again. And while the fellows were preparing a microcatheter and the guide wire to catheterize and to use a stand, he tried it several times without any success. So then they went for a stent retriever, and they did 2 passes of combined technique with a Trevo and with a SOX Fast 6, but there was massive clot burden here, so they didn't manage to retrieve anything. There was a discussion in these cases before I was doing double stent retriever, trying to bring this major clot out. Now they decided to stop altogether. They put the Thermo 2038 guide wire inside of the carotid. They exchanged the Neuromax, they exchanged their short sheet, and they went with the Sophia 88, went with an arrow. Because they had no recanalization before, and this is the Sophia 88 mounted to the T. They didn't want to start doing another pass directly, so they just put a microcatheter in, changed also the stent retriever because they thought might based on stent retriever related technique, choose an ember trap. You can see it here. It's the 6.5 by 45, and they had the first pass recanalization in this patient with this setup. First pass, it was a 6th pass probably, but you understand. And just doing a procedure duration, they were spending around 60 minutes before the exchange, doing all this catheterization and combined techniques, which is something that we saw in the literature, how much it takes. But then after the exchange, the vessel just opened up after around 15 minutes. You have a prefrontal emboli, but I think this is the least problem to the patient and wouldn't chase this after. Another case that is very interesting from the purpose of it's a carotid T with a long M1 thrombus going into the M2, as you can see. And what's very interesting to me retrospectively, I always look at this imaging, look at the M3 branch there. It's very hyperdense. I do not know if there is a thrombus there or not, but I see something there, and this is, I think, relevant towards what we have and what we believe that we control or do not control with our stent retriever and aspiration approaches. In this case, they thought it was didn't show you the CT scan. They thought it was a T. There was some calcification down, but the carotid was missing, and they went with the arrow 8 French, and yeah, it was a tandem occlusion actually. So you saw the balloon guide moving the arrow on the balloon that and trying to put it in the carotid that was discussed before. They gained intracranial access, and they started mounting the Sophia 88. And on my advice, because it was one of the first cases, I told them, start aspirating while you're moving towards the Petras, because being occluded up and being occluded down, I thought that the whole carotid is full of thrombi, or there was no blood flowing there. And while they were doing that, after they reached the cavernous segment in this situation, they also had this success of remote aspiration while still having, as you see, some distal emboli in M2 and 3. This is something that I do not know if it's good or bad. I still have to get more cases to understand if we should remote aspirate or if this facilitates distal migration. I think it helps because it clears the big part of the clot. And what usually happens with this kind of remote aspiration is that I never get A1 emboli because I take the first part of the clot out, and this is A1 emboli is something that A1 A2 was something that I always fear. This was managed with another aspiration attempt. And while retrieving these aspiration catheters, when we have a distal emboli, we always mount the large bore towards the M1, covering the A1 origin and ensuring local flow control whenever we connect a syringe to the large bore, and whenever we get the smaller aspiration catheter at the level of the M1 to get inside the large bore, then we start aspirating on the large bore, not to collapse the M1 and to lose some fragments of the thrombi that might be at the catheter tip. this was a fine result in the end. The vessel recanalized, had some distal emboli in another branch. They decided to stent the carotid artery afterwards because the plaque was not good and because we usually stent all our carotids, and this is the final result. This was the case from last week. I was called to do in a 70-year-old female, and when I opened Rapid and I saw the imaging, I was like, okay, she has a sequela on the other side, she has a stroke on the left side right now, aspects is not so good, should we go in or not? Because my biggest problem here was that you see the whole common was missing, and I was not at the start I was not sure how I will recanalize this artery, especially thinking it was atherosclerotic, but the size of the vessel is big, even if everything is missing, and you do not have a lot of calcification. So I said, probably is a full thrombi in all of this region, and I saw that the patient had collaterals. She had intracranial vessels. So I thought, okay, let's give her a try. Let's try to recanalize it and let's see what happens. I took a 5 French Simons, saw the common occlusion, put a 38 Terumo in, and this is a case, in my first case of Cerebrovascular 92, I just halved them. So I received them 1 or 2 weeks ago. So I put the Arrow 8 French in the common and I start doing passage, just pushing the Cerebrovascular 92 and aspirating. I cleaned the common. I had to retrieve it in the arrow a lot in order to get the positive pressure of the arrow and of the origin of the common so that it pushes my thrombus inside and get it in the syringe, because it was constantly blocking. So I managed to open up nearly everything, and when I went into the carotid artery doing the same aspirations up to the cavernous, I even managed to open the T before even trying to pass the cavernous in this patient. And you can see there is an M2 and M1 trifurcation with an M2 emboli, which we afterwards recanalized with the red 62, which I put in the Cereglide. Now, the Cereglide 92, for now, the only available size is 122 centimeters, which made it a little bit more difficult to use the red 62, which is 140, and with the valve, which is 7 centimeters. So there's a big discussion to have on what is the ideal size of this large bore if you want to use them afterwards quadriaxially or triaxially for more distal passes. And I think in the range of 115 is enough, or everybody should have small valves in order, like Toriborg valves, in order to be able to push some more distal catheters to go distally. So this was our usual setup for using this large bore, 8 French short groin sheet. We usually did exchange maneuvers for everybody, putting an 8 French arrow inside. I was doing the exchange maneuver directly in the carotid or in the external because I wanted to be sure that it's a carotid T, and I don't want to use these catheters for M1 for the moment. But I know you can do the exchange and you can mount up an arrow from the start in the carotid, and I think some people are doing that and they can further elaborate. Using the 38 Terumo guide wire, I had never a problem of pushing my arrow 8 French, even in very difficult anatomies. After that, I use these catheters and I mount them in aspiration until they block, and then I decide the way to navigate after the cavernous. However, with these devices, you cannot go triaxially with the diagnostic catheters until now. Probably only the wrist burn, 130 centimeters would have been enough, but I never start using a vertebral in a stroke patient. It's just I'm going Simons because I know I will use it. Right now, there is a diagnostic catheter that is 150 centimeters, the ISAC by microvention, and I had the chance of using one in this patient that's 55 years old, had atrial fibrillation, and 2 hours from symptom onset. I got the imaging, was looking at the anatomy on my way towards the hospital, saw that it's a T occlusion, M1, and you can see the he has a very big PCOM on the right side, big PCOM, and then T and M1 is disappearing. So I said, okay, very straight anatomy, young guy, atrial fibrillation. I will just try the ISAC out. So I catheterized with the diagnostic catheter with the ISAC on a Thermo 38 guide wire directly, and I put in the Sophia 88. So I had the diagnostic catheter inside the Sophia 88 115 without any arrow sheet at all. I was just using a Terumo 8 French short sheet in the femoral. So basically without a guide catheter. Pushed the Sophia 88 in the carotid, did a run. You can see at this point that he has a very big PCOM. In this kind of cases, I wouldn't remotely aspirate because I don't see how this would work, because you have flow from the PCOM, you're probably aspirating this all the time. So then I just pushed the Sophia 88 catheter up with the Terumo inside. And you can see here, we managed to snake it. This happens, in my experience, around 20% of the time with these aspiration catheters in very good anatomy. You can just snake them past the ophthalmic without pushing too much, and you get to the M1, TM1, where the thrombus was. And we did one pass, and this has a first pass recanalization without using a guide catheter at all in a patient that's true who had a very favorable anatomy, and this is like a TK2C, and he did perfect. He had a perfect recovery, and this is the total fluoroscopy time of this patient for a big T occlusion with a total duration of less than 5 minutes. So I think this is something that happens, and this is something that can help out these patients. Another thing that is now available and that I recently started using, I had a case in which I did it, because up till now we saw that I was always mounting them on a Sophia 6 French to pass the ophthalmic. In this case, did a remote aspiration in a T occlusion again, and managed to open up the first part and the A1, which is the most frequent thing that happens with these remote aspirations. And I usually do not have emboli in the A1, but still not a lot of cases. And then in order to pass the ophthalmic, we use this wedge catheter, which is like a balloon on the microcatheter that fits the Sophia 88, a kind of delivery device, and you can see how easy it goes on this wedge with the 14 Chikai black. So only supple part, this is passing, and then it was very easy to navigate it into the M1 and to do a run. This was a pass. I tried to push it a little bit in the M1 when I started aspirating, just to inglobate the clot and have everything out. So this is how it works. And now, these are my home points for people that start, and this is my small experience, because I have around 20 cases. Always keep to a low position of arrow F French, and I think it's mandatory not to have problems. Stay at the bulb of the carotid, not more, because you might get spasm. Choose 80 centimeters long sheets, not 90, because you will have length issues. Try to choose more supple ones. Remote aspirating works in 20-30% of the time, but we might target that it might lead to emboli in distal territories. So I'm not sure that is the way to go. I'm currently using it, but it might change. Tracking is excellent if you for both catheters, Celegride and Sophia that I'm using, and you can mount them easily on other aspiration catheters if you need to, but they also have their tracking devices designed for them, and they work pretty fast and pretty fine. And think about these large bore catheters, in my opinion, as a new concept for flow arrest and flow control, because once you have them in your ICA T terminus or M1, you are basically having a balloon guide up there when you start aspirating or anything with them. So it's like having a balloon guide near the occlusion all the time, not having a balloon guide at the origin of the neck. I'm always using Terumo 38 guide wires for exchanges, and I think I cannot emphasize how much this works and helps me out. And the people that are using just 35 guide wires, they should try it out because it makes their life much more easier in terms of navigating difficult arches and straightening vessels. And this is pretty much everything. And I'm waiting for your comments and discussions and. Let's see how you are managing this class. Thank you.
Thank you. Thank you very much, Razvan. Very informative. And so you work now more and more with these large bore catheters, I see. Do you measure the vessel size sometimes?
No, I do not. Mostly, I think for carotid arteries, there shouldn't be a problem. Like they're around 2.4, 2.5 centimeters.
Mhm.
And I didn't really start using them in M1 occlusions because now it's a problem of cost also. They're most cost expensive, and in my situation, this might be a problem. But we have good results with normal catheters, like normal aspiration catheters, 70, 72s, and if you might need a stent retriever. And I want to have more experience. But definitely they go to the M1. However,
Yeah.
you will not be able to use them in an M2, definitely, and I think this can be a problem.
Yeah. I saw in the example you gave that you go easily to the M1 with this 88, so that's not a problem. You said you don't use balloon guide catheters, and Fatma, I think you don't use balloon guide catheters either.
Yes, we generally don't use balloon guide catheters. One of the reason is cost issues,
Yeah.
and the second one, we don't see too many distal emboli in our cases. I
No.
don't know why.
Yeah, that's
Uh,
what we still use it. And I don't know if you really prevent distal emboli, that is the idea, but it gives some other options. For example, but with the stent placement, you showed, Fatma, that you use a distal filter. Nowadays, we use a balloon guide catheter and do proximal occlusion and aspirate while placing the stent and while dilating the stent. So that's also reason to use it.
I also use balloon guiding frequently. Especially I choose the patients, and if there is a T occlusion or tandem, I use balloon guiding catheters generally.
Yeah.
It depends on the anatomy, but if it's M1 with the current technology, I'm not sure that it's always necessary. But if it depends on the clot burden, it depends on the anatomy. So definitely tailored approach, but still balloon guidings are quite important, to be honest.
Yeah.
I
Attila,
agree with
Attila,
you.
Wim, do you use the newer generation of balloon guides or do you still use Mercy Cell old generation balloon guides?
We don't have walrus.
Mm-hmm.
That's the problem. So still we are lack of, but I start using Bobby.
Mm-hmm.
Yeah.
It's good. It's compatible with tortoise anatomy, but the backup it has some backup problems.
Does
Uh,
it go in the Peter segment? Can you put it in the Peter segment or not all the time? This is.
Not all the time, not
Mhm.
all the time, to be honest, but it's better than for sure older ones.
Yeah, we still use the old ones. I did the case just before, and we used the Mercy, and I used the Mercy 9. That was a
Nine
lot.
French.
The Sophia 6 and then a Red 68. But we have the Walrus, but it's quite expensive in the Netherlands, and there's
Yeah,
not that much
different.
advantage, I would say. Not well. There is a little advantage that you can get a bit higher. They're more subtle than the old ones, but still, with the old ones, we can get up to the just below the skull base, which is good enough for us, I think.
So we have a paper with new generation balloons, haven't published yet, with St. Mike's group in Toronto. They use Emboguard and Bobby frequently there. And to be honest, the results show more like vasospasm, severe vasospasm, uh, much more dissections with these newer generations. but again, haven't published yet.
Okay,
Yeah.
so pleasant because they place them more distally.
That's right.
I think one of the reasons why I don't use balloon guides, and I was trained with balloon guides, Vim. I was actually using your setup all the time because this is the way I was trained in Montpellier. But the thing that made me change was actually the Cerebase and this very navigable long sheets that I might reach the cavernous all the time. And then for me, it's very easy to do a second pass or to manipulate flow or to do things. And I see the large bores as if it wouldn't be for the cost issues, frankly. From my approach, controlling the flow at the carotid T with a large bore in an M1 or in an M2 case, the support it offers, the way you can afterwards track your smaller catheters, it's like having, your guide catheter at the level of the carotid terminus. And I think this will change the way we're managing stroke because you can control everything from there. Just aspirating, you collapse the vessel, you control the flow.
It depends on the logistics, I guess, the price and the logistics of
Yeah,
your
yeah. If
center,
it
your
wouldn't be
country.
for the price, this is
Yeah,
what I'm
I
saying.
agree totally with you. If T occlusion, I don't have the very large bore catheters in Turkey right now, so I still use balloon guiding. But for M1, N1, as you mentioned, I use now Cerebrase. It goes up to cavernous segments very easily. Then I don't use balloon guiding at the. It depends on the anatomy, your logistics, price, economy, and all this kind of things, availability.
Yeah, I'm not so convinced either anymore. You showed us on this ProFate study, which still showed some benefit, but there's also the Chinese Protect MT study comparing and randomizing between balloon guide and non-balloon guide, and balloon guide did much worse than non-balloon guide. So, well, it's still under debate. Yeah, and for another topic that Fatma showed one where you place the stent, what kind of stents do you use for intracranial stenting?
Credo. Nowadays we have Credo and Pegasus. Sometimes we use coronary stents for posterior system. To be honest, balloon expandable stents, especially for V3, V4 stenosis. But we have those two for ICAT.
Yeah. And the last one you also used Credo?
Credo.
I have just two Credo cases. I recently got it. Most of my intracranial stents are balloon mounted stents. Whenever I need to stent, if it's a straight, so if it's MCA base or whatever segment that I do not have different calibers, that I need to go from 2 to 3 or 4 millimeters, like from M1 to the carotid. I'm still a big coronary stent user, and I always switch my setup in these conditions to 5 French Navian, in which I park in the cavernous, and then I push in a very undersized coronary stent all the time. So I undersize towards the target vessel. For MCA, I always take 2x9 Resolute or 2.25 by 9 Biotronic stents. And I inflate only to 6 atmosphere, 4, 5 atmosphere, 5, 6 maximum. And for me, I have these good results with this stents. One thing I learned, Fatma, because you saw your case of losing the coronary stent, is I try never to manipulate this coronary stent in the cavernous segment a lot. So if it doesn't go easy, I prefer to mount a 5 French Navian or 125 Sophia after the cavernous segment and put it inside, because it once happened to me trying to push it strong to go through these cavernous segments, that I got the same thing and I ended up snaring for 60 minutes until I got it out. So I think the lessons to be learned about coronary stents is that you should not force them inside the vessel and try to keep them inside intermediate catheters all the time, and then you will easily stent with them.
Just to correct, we were trying to put that coronary stent to right V1.
Yeah, but I explained why it can go up of the balloon. I understood that it was not in the time. So
But a good lesson. We know it from peripheral stenting that if you have balloon mounted, that you want to place them sometimes what we call protected with a long sheet. And here's the same. We use also balloon mounted coronary stents nowadays, even in the anterior circulation. But it's a good advice you give that be careful in the siphon that you, well, bring it up protected maybe in a longer intermediate catheter.
I always have 125 6 French catheters on the shelf, and they are especially for this coronary stents because if I have a difficult siphons, I bring them to the T, and then I just put my coronary stents into
Yeah,
it, the small
yeah,
valve.
very good. Yeah.
And hopefully we will not experience the same thing again. But I also spent like 15 minutes with snare to retrieve this
Good.
stent. After separated stent like embotrap, just catch it.
Okay, I don't know if there's one question now, and I think if we come to the end, you all have to know that you will receive an evaluation form later. Yeah, it's in the screen now. You will receive this, and you have to fill it in, and then you will get your CME credits afterwards. Are there any other questions left by you, Professor?
I have a question for you
Ah.
because I was debating with my residents while trying to build a database around these large bore cases. How would you think about this remote aspiration thing? Would you consider it a pass? Or would you not consider it a pass? Because the question is, okay, I've done an aspiration and my first pass is sticky to A or 1A or what, because I just opened A1. Would you put it as a first pass or would you just consider that the first pass is when you reach the target clot?
Well, that's a good question. I would think if you start aspirating, I'm not a fan, or I never do remote aspirating. If I don't reach the clot, then I will continue with the microcatheter and the stent retriever. And I know the examples shown here also that with the remote aspiration, you can collapse the vessel. And then nothing works anymore. But if you do it, I would still consider it as a pass, as an attempt. Then call it an attempt.
I will definitely separate the entity. If you want to look at the remote aspiration effect, then you have to separately enter it as a remote aspiration, not as a pass, to be honest.
Yeah, because for me it was if you judge, then you always have two passes, right? If one was not good, but actually you did not lose a lot of time while doing this, and you did not damage the blood vessels intracranially. And I know that you can collapse vessels. I think it's more. This is why I don't understand how this sometimes works, because it's a big catheter that we are, and it's not collapsing the carotid, and then having questions why. But I think we'll have more experience in the future.
Well, we've seen examples. I think it was even from Montpellier where they did remote aspiration in a stented carotid, and even the stent collapsed.
Yeah.
Yeah.
Especially with balloon guides. If you have the balloon
Yeah.
guide,
Okay, Professor Ozdemir, you think we had a good session?
Yeah, excellent
Hello?
session. Thanks, Dr. Weem, Dr. Fatma, and Razwan. Thank you.
Yeah, and for all the attendees, very happy you were attending. Don't forget to fill in the evaluation form, and then we'll hope to see you in the next occasion, webinar, or meeting. If you come to Maastricht, that you show behind me here, you're all welcome at ESOC in
Yeah,
May.
we'll be there.
Okay.
Thank you.
thank
Thank
you.
you.
Thank you.
Bye.